तो फोन मीटिंग के लिए Uh, Dr. Amit, Dr. Amit, have you joined? Hello. Is there anybody from Three Dots Life Science?
Yes, sir. Good afternoon.
Yeah, good afternoon. Just convey to Dr. Amit to join.
Oh, okay, sir.
Hello.
Hello, Amit. How are you? Good afternoon.
Sir, good afternoon. Very good afternoon, sir.
Yes.
Sir.
I think
Sorry,
it's.
sir. I was traveling.
You're traveling. Okay, okay.
I will be reaching my place in just 1 or 2 minutes.
Okay, sure, sure. Okay, take your time. Yeah. Yeah, Three Dot has Dr. Tiwari joined? Yeah, anybody from Three Dots?
दो मिनट में ज्वाइन कर रहे थे
Have you asked Dr. Vishnu to join? Hello.
Hello.
Yeah. Just want Dr. Amit, I just want to know, has Dr. Vishnu joined or not?
Uh,
I think he has not joined till now.
I'm not able to see him. Uh, Let me connect.
Hello, Dr. Amit.
Sir,
Sir, good afternoon, sir.
Hello.
How are you? Good afternoon,
sir.
Dr. Tiwari sir.
Good afternoon, sir. Good afternoon.
Sir, good afternoon.
Good afternoon, sir.
Good afternoon. How are you, sir?
Fine, sir. Fine. Thank you.
Fine.
Thank you. Thank you. It's nice class going on.
Yes,
I'm
sir.
very proud
It
of
is.
you.
Yeah. Now your child is growing fast.
Thank you, sir. Thank you.
Yeah. So it has become a very popular CME program now, and I think you have
Yes.
set a new
It is due to blessing of few people, sir.
nee, sir.
Blessing of people.
It's the new beginning, which I think will continue. This program should continue forever now.
It will, sir. Definitely.
Yes, sir. Now, how is now your place? Is it very hot? In Jaipur, we have a alert
Not,
for heat wave in Rajasthan.
not very hot. Bit summer is there. Not
Yeah.
very hot. And
Hmm.
nights are pleasant. Nights are pleasant.
Yeah. Now, in Rajasthan, there's a alert for heat wave. So it's touching around 45 degrees Celsius in some places.
No, it is very hot there.
Hmm.
It is
how is
pleasant here at the moment. Yeah, come on,
Yeah,
mate.
Dr. Amit, has Dr. Vishnu joined?
No, sir.
Just give him a call. I can't hear you. Unmute yourself. Amit, you are not audible.
Dr. Vishnu Sharma has yet to join. We are trying to connect to him. And
Okay.
I've talked to Dr. Daria.
Hmm.
We are just trying to make it fast. How's the temperature at Jaipur, sir?
It's around 40, 41 degrees Celsius. Pretty hot.
Okay.
Yeah.
Oh, it is become very
So
hot.
in Barmer, Jaisalmer, it has touched 45 plus.
My God.
Hmm.
We are
So,
also expecting a tremendous heat this time around. No? Just in the
so
next 15 days,
hmm. Yeah, it's going to
uh,
be, yeah.
it's going to increase.
I think like last year,
So
we will
last
have
2 to 3 years, there has been evidence of heat wave.
Hmm. Last year was pretty bad. It was so hot for a prolonged period. I think this is a global
Yes,
warming which is affecting all of us,
global warming phenomena.
and
Yeah.
and still we are not so much aware.
Yes.
Nor the government is taking any steps. nor the citizens are taking any steps to how to actually halt this global warming. Yeah, very soon we'll have power crisis, electricity crisis in the state.
Yes. Yes, yes. No, people are dying at their home also. No? Last 2 years back, people used to sleep at night and they were having, heat stroke in
Yes.
the early morning. So that was happening.
Yes.
That was very bad.
Yes. It still happens in
That,
areas where they are not accessible to basic healthcare facilities. So we have large parts in the country where still health services are not to the mark. Even
yes.
the basic health services are not available to the population. I think it's already 1:45. Have you called Dr. Vishnu, Amit?
Uh, uh, Dr. Daria is talking to him. I tried to call, he was on phone.
Acha.
Yes.
Okay. Okay.
Dr. Daria is trying to call him. Just give me a moment. I'm trying to call him
I
again.
think from next Tuesday onwards, I think we'll request the speaker to send mail the slides PPT at least before. Yeah.
Hello, Mehta sir.
Yes. Yes.
Uh, Dr. Vishnu is not able to connect. His mobile is continuously engaged. Dr. Daria is also not able to connect.
Okay.
Meanwhile, sir, can we
Yes.
take some questions randomly on the topic today, hemophilia? Sir,
Yeah.
what is your take on the hemophilia uh, patients of India? What is the prevalence of hemophilia, and what are the common types of hemophilia?
Yeah. Yeah. I think it's still a very underdiagnosed, under-recognized entity in the country. And I think it's only around 17 to 20% of the actual number of hemophilics have been identified or and are under treatment. So still, because this is partly because of lack of awareness among the physicians and especially in the rural and the semi-urban areas regarding this entity, hemophilia. And then there, of course, the lack of facilities to confirm the diagnosis. So these laboratories facilities are available only in big medical colleges. Many of the medical colleges even do not have the lab to estimate factor 8 or 9. And therefore, this is, I think, the main, these two things, the lack of awareness and knowledge among the physicians and the residents in the medical colleges, as well as lack of the testing facilities. That's why this entity has remained under detected in our country.
Sir, when would you suspect hemophilia in the usual clinical ways?
I think any patient, any child or young adult or anybody who comes with an unexplained bleeding episode, especially bleeding in the joints, hemarthrosis, or then you have bleeding in the abdomen, intra-abdominal, this was hematoma is there, or patient has unexplained bleeding from the nose, epistaxis there or from the gums. And many times you have patients who are diagnosed. I've seen patients have come, young patient have come with intracranial hemorrhage. So these are, of course, then these are the patient one should always, I think, suspect that are they having hemophilia or not. And of course, the history is important. Clinical history is very important as to one has to assess how many bleeding episodes have occurred, what was the age of the patient when first bleeding episode, what was the site of bleeding, and of course, the family history is very equally important, the most important. Many times, what happens, you ask the patient, they deny, but somehow later on they say, yes, one of my brother was hemophilic and he died because of intracranial hemorrhage and so on. So it is very important to take, one has to actually intrude into patients uh, uh, to take the proper history. And history is very important. The moment you take a history of bleeding disorder coming in the childhood, first manifesting, of course, that would be a clue that patient has some congenital cause of bleeding, and of course, hemophilia is the commonest cause. And of course, the other they acquired him because the one Williamson disease, of course, it is milder in nature, except for few subsets of patients who also behave like hemophilics. But one Williamson disease is usually detected later on because of its mild nature as compared to hemophilia.
Right, sir. So any bleeding disorder, especially of the joints, you should start thinking of hemophilia.
Yeah.
And
Anything
yeah,
unexplained, one you
unexplained
cannot ascribe to any cause.
injury,
Yeah,
trauma,
yeah, yeah,
infections.
yeah, you're right.
So and recurrent hemarthrosis should always be the red flag signs for
Right.
hemophilia. Hemophilia.
Right. Absolutely right.
And VWD or Van Willebrand disease is a slightly milder variant of and the deficiency of factor 9
Hmm.
is one cause. The usual scenario, we have the Hemophilia Society, and
Yes.
the Hemophilia Society provides blood components and especially the factor 8 for
Hmm.
hemophilia patients, and they are doing wonderful. Uh, uh, Sir, what according to you would be the dose according to the sites of bleeding of the
It's
factor
about
8?
Yeah, now the standard of care is now the prophylaxis, and depending upon the severity of factor deficiency one has, and then depending upon what is the dose you require, the one which is being followed for prophylaxis in the developed countries as compared to the low dose, which was the first Chinese people which came on low dose prophylaxis because that would improve the quality of life, and especially in those areas where we have economic constraints are there. So the dose, as what the World Hemophilia Federation has conveyed, that the doses depend upon if the patient you're treating in the healthcare facility belongs to a developed nation or underdeveloped country. So in India, I think many people, of course, use the full dose that is, and many of us also use low dose also. Though these factors now available free of cost in many states, including Rajasthan, these factors are now available free of cost in the government hospitals. Yeah, Dr. Amit, were you able to connect to Dr. Vishnu? No. Yeah, you please unmute yourself. Yeah, yeah.
Sorry,
What
sir.
I said. Yeah. Uh,
Uh,
You are not
Dr.
able to
Vishnu,
connect to Vishnu.
Dr. Vishnu is joining in 5 minutes.
Okay.
Unfortunately, link was not sent to him, so he was not knowing when the program is and what's all about this. So
Oh.
there is slightly goof up, possibly Dr. Daria, who has been traveling international, so
Hmm.
slight misinformation or miscommunication was done. But he's very kind enough to join and start his class in next 5 minutes.
Yes, good, good. Because that's a very important topic,
Mm.
and many of the thing the attendees here will be are working in the medical colleges and the
Mm.
government, especially in the government medical college, where you have facilities for free factors. So I think almost all over the country now of course there are hemophilic societies are there, which gives you these factors in very subsidized rate. But now I think almost all state governments are providing free medical care to patients with hemophilia. So how often you see these patients,
Sir,
Dr. Amit?
we have the Hemophilia Society working in our medical college who are providing the factors. And these patients very frequently come with bleeding disorders, especially
Yes.
of hemarthrosis. The most common is
Mm,
hemarthrosis. And we see these patients at least 5 to 10 patients every month coming to us.
mm,
Most of them are diagnosed people who come with bleeding disorders.
yes.
Patients in OPD, fresh patients in OPD are less, but
Mm,
follow-ups are very frequent in our colleges. So once they have been diagnosed and they have bleeding, they come and they are trained well trained by the people who are in the Hemophilic Society, the NGO who is
right.
working with they train them well, and factor eight is transfused very frequently here.
Okay. Uh, acha. Bhabhi ji. Ah, uh, yeah, this. Uh, your is a private medical, government medical college.
This is a government medical college.
So you must have free access of factors from the
Yes,
government.
yes,
Yes,
free access,
it's
free
free.
access.
Free. Right.
So that's why follow up at our center is huge.
Yes.
So it's free and it's doing good
But how many
because
patients are on prophylaxis, taking prophylactic treatment? That is the standard of care in these patients. But they're coming for on-demand therapy, I think.
on demand therapy they go to the hemophilic society. They have their own registered OPD and they get
Okay.
the treatment there itself. They're not in the usual care. They don't come in the OPD. So
Okay.
the prophylaxis is with the OPD running there.
So you
They,
don't have a specialized hemophilia
uh,
treatment center STC at your place?
no, we don't have that here.
Okay.
Let's just set here.
Then what factors are available there? The recombinant one, I think now it's recombinant factors are available all over the country.
Recombinant factors are available at our
Because
place.
plasma derived now, because of it's not possible, because plasma is not available.
Mhm.
So recombinant is coming.
It's coming high, and it's available. Means accessibility and availability are no issues here.
Yes, yes, I think that's how the technology has improved the
Yeah,
treatment of hemophilics. I think that's
you
tremendous.
must have seen the entire journey of the woes and problems of hemophiliacs dying with bleeding, and
Yes,
how comfortable they are living their normal life.
right, right,
That is the achievement of medical science. One of the key
right,
achievements of medical science. Yeah.
right, right. But still, we see a lot of joint deformities,
Yeah.
hemophilic arthropathy, just because of the ignorance of the patient or the parents that they are all have target joints are there. Mhm. But
Uh,
overall, things now improving. I think it is improving, and I think now they have a brighter side of life. The hemophilics have brighter side of life now,
yes,
and
definitely.
the government support is tremendous, tremendous.
I think Dr. Vishnu Sharma has just joined.
Yes.
Uh, Dr.
Yeah.
Vishnu?
Am I audible?
Yes, you are, sir. Thank you
Yeah.
for joining. And I'm extremely sorry to the entire audience for
No problem.
slight miscommunication with Dr. Vishnu Sharma. And he is kind enough to join in this very short notice. We welcome Dr. Vishnu Sharma. And may I request Dr. Sudhir Mehta to just introduce Dr. Vishnu Sharma, sir, please.
Yeah. Dr. Vishnu, hello. How are you?
Yes, yes, sir.
Dr. Vishnu is Associate Professor of Clinical Hematology, which is a part of the Department of Medicine as SMS Medical College. And I had the pleasure of working with him. He was with me for, I think, 4 or 5 years as assistant professor before he went to AIMS New Delhi to do his DM in clinical hematology. And now he's a senior faculty associate professor, and which is clinical hematology now is a part of subdivision of medicine department of medicine. And soon, I think in probably this year or maybe next year, we'll have a full-fledged department of clinical hematology at SMS Medical College. Now, without wasting much time, I'll just invite Dr. Vishnu to deliver the talk on hemophilia. Dr. Vishnu, over to Dr.
For
Vishnu.
your kind word and kind introduction. So my slides are visible, sir?
Yes, yeah, they're
Can
Uh,
you see
visible.
my slides?
you can
Yes,
just put it on slideshow. That would be nice.
Sir, can you see my slides? Is it
Yes, we
visible?
can.
Slides are visible or not?
they're
Yes, we
visible,
can.
visible.
Can you see my slides?
Yes, sir.
Okay. So good afternoon. Sorry for the delay. So I'll be speaking on the management of hemophilia. So this is the overview of my presentations and the findings. So we know there is a critical balance which is necessary to maintain the blood in a fluid state. So whenever there is predominant of one component, patient either thrombosis or bleeding. So hemophilia is a kind of disorder where the clotting factors, patient becomes prone for bleeding. So it is also known as royal disease, hemophilia B, because it was prevalent in the royal family of Europe. And we know that hemophilia A is because of deficiency of factor 8 and hemophilia B is because of deficiency of factor 9. And both factor 8 and 9 are necessary for the ultimate formation of thrombin and subsequently fibrin generation, which is an integral part of clot and hemostasis. So it is a rare disease with prevalence of 1 in 5,000 hemophilia A in males, and it represents around 80% of all hemophilics. Hemophilia B is relatively uncommon with incidence of 1 in 30,000, and it represents around 15 to 20% cases of all hemophilics. So other rare bleeding disorder include hemophilia like VWD, factor 7 deficiency, factor 10 deficiency, 13 deficiency, the platelet function defect like Langerhans thrombasthenia, Bernard-Suter syndrome. So these are other rare bleeding disorder. Hemophilia is commonest secondary hemostatic defect. Commonest bleeding disorder is VWD. So coming to the inheritance of hemophilia, it is a X-linked recessive disorder. So females are generally carrier, and it is very, very rare to have the hemophilia in female. Predominantly it is a male disease, but female can also develop hemophilia. So if the mother is carrier, there is 50% chances that the male becomes hemophilics and 50% chances that female child becomes hemophilia carrier. So inheritance is again very, very important to understand the preventive strategy of hemophilia. Coming to the signs and symptoms of hemophilia. So it is a disorder of secondary hemostasis, and a patient becomes prone for spontaneous bleeding or even minor trauma or traumatic events can cause bleeding. So a patient can have excessive bleeding from cut or injuries. Nosebleed can be there, blood in urine or stool, large bruises can be there, swelling, pain in the joint, and increased bleeding after surgery or dental work. And commonest site of bleeding in patient with hemophilia is either joint or muscle hematomas. So coming to the incidence of different site of bleed. So commonest site, as I already mentioned, is joint and deep muscles. So joint bleed constitute around 70 to 80% of all bleeding episodes. life-threatening serious blood bleeds can also happen in less than 5%, which includes intracranial bleed, retropharyngeal bleed, or sometimes gastrointestinal bleeds. And the serious life-threatening bleeds requires urgent attention, and sometimes it can be fatal also if not treated in time. So it is very, very important to identify the bleeding site, and the further treatment is decided by the severity of hemophilia, type of hemophilia, and site of bleeding. So as I already mentioned, weight-bearing joints are commonest site of bleeding. 20% knee joint, 42% ankle joint. Other joints, large joints, elbow 21%, shoulder 4%, wrist 2%, and hip joint 4%. So commonest joint which are involved in hemophilia are weight-bearing joint, ankle, and knee. And repeated bleeding may lead to permanent damage and deformity and disability. Coming to the diagnosis. So diagnosis of hemophilia is relatively easy. It's not very difficult. So someone comes with bleeding history consistent with hemophilia, like someone is having repeated joint swelling, repeated muscle bleeding, swelling, you should suspect for hemophilia, especially when the bleeding history in the family is there. So it is important to look for the bleeding history in maternal side because of its unique inheritance pattern. So clinical history, especially the maternal side, is important. Physical examination to look for joint swelling, pain in the joints, or muscle atrophy, deformity, the like flexion restriction, extension restriction are important. Laboratory investigations includes simple tests like prothrombin time, APTT. So in patients with hemophilia, you will find normal CBC. You can have mild anemia because of bleeding, but CBC will be essentially normal, PT will be normal, and APTT will be prolonged. So whenever you encounter a patient with bleeding history consistent with secondary hemostatic disorders with isolated APTT prolongation, you should suspect for hemophilia. And there are limited causes of isolated APTT prolongation. Commonest is factor 8 deficiency. Second common is factor 9 deficiency. You can have factor 11 deficiency. 12 deficiency, patient will present with APTT prolongation, but bleeding will not be there. So prolonged APTT, normal PT with normal CBC, you should suspect for hemophilia. So in hemophilia A and B, PT will be normal, APTT prolonged, normal BT, normal platelet count, and a definitive diagnosis is made by doing the factor assay. So first test is APTT, second test should be mixing study in which we mix patient's plasma, 50% of patient's plasma with 50% normal pool plasma. If APTT gets corrected after mixing, it indicates the congenital factor deficiency. If it remains prolonged after mixing, it indicates the inhibitor, which can be there in patients with acquired hemophilia. It can be there in patients with SLE, antiphospholipid syndromes, or other autoimmune disorders. And confirmation of diagnosis is done by doing the factor assay, factor 8 or factor 9 assay. So in patients with, in normal person, the factor levels will be 50 to 150%, but in patients with hemophilia, the factor 8 or 9 level will be less than 40%. So based on the factor level, we divide patient into mild, moderate, and severe. In patients with mild hemophilia, which in hemophilia A, which constitute around 28% of patients, the factor level between 5 to 40%, and spontaneous bleeding is rare in patients with mild hemophilia. And these patients generally bleed when they encounter a trauma or surgery. Moderate hemophilia, around 19% patients, factor level between 1 to 5%, and occasional spontaneous bleeding can be there. But these patients are obviously prone for bleeding with minor trauma or surgery. But it is important to understand that the factor level generally these things are arbitrary. Some patients with moderate hemophilia can behave like severe hemophilia, and severe hemophilia genotypically or based on the factor level can behave like moderate hemophilia. So it is important to look for the bleeding phenotype rather than the absolute percentage of the factor levels. Severe hemophilia, around 50% patients, factor level less than 1%. And these are the patients where bleeding episodes are spontaneous. And because of repeated bleeding in the joint and muscle, patient become debilitated and morbid by the age of 15 or 20. So this is how we can classify hemophilia based on the factor levels. So coming to the management of acute bleed. So hemophilia management can be broadly categorized into two headings. First is management of bleeding episode. Second is prophylaxis. So first of all, we'll discuss about the management of acute bleeds. So PRICE is first aid strategy for management of any bleeding event in patients with hemophilia. PRICE, P stands for protection, R stands for rest, I stands for ice application, C for compression and elevation. But definitive treatment is clotting factor replacement, which should be done within 2 hours to prevent the long-term complications associated with the bleeding. So this is very, very critical for the optimum outcome of the bleeding events. So early treatment of acute bleed, there are multiple guidelines, including WFH, UK CDO, which highlights the importance of early treatment of bleeding episode, because the early treatment is the only way by which we can prevent the long-term complications of bleeding events. So please suspect the bleeding and treat immediately and with optimum amount of clotting factors. Aura is very, very important uh, to like predict the bleeding episode, and ideally patients should be treated within the aura time. Pain management is also an integral part of hemophilia management. You should avoid the aspirin and other NSAID, paracetamol and tramadol are the ideal analgesics for patients with hemophilia, because the NSAID and aspirin interferes in the platelet aggregation, and these drugs should be avoided. Selective COX-2 inhibitors can be used, like torigoxib, celecoxib can be used in patients with hemophilia, but you should avoid the aspirin and other NSAID. So treating the cause, adequate and timely CFC, along with PRICE, which is a first aid management strategy. Coming to the dosing of the clotting factor concentrate. So factor VIII how do we calculate the dose of factor VIII? So we know that the half-life of factor VIII is around 12 hours, roughly around 12 hours. So we need to give factor 2 times a day. The half-life of factor IX is around 24 hours roughly. So we need to give factor IX once in a day. So how do we calculate the dose of factor VIII? So body weight into desired level. For example, in a 50 kg person, we want 50% of factor VIII. So 50 into 50 divided by 2. So it becomes, this is how we can calculate the dose of factor VIII. For factor IX, body weight into desired level. So 1 unit of factor VIII increases the factor level by 2%, and 1 unit of factor IX increases the factor level by 1%. So that's why we divide body weight into desired level by 2 for factor VIII. But for factor IX, we simply the multiply body weight into desired level. So various factor products are available in India, including the standard half-life, extended half-life products are also available. So we have plasma-derived factor VIII preparations, we have recombinant standard half-life preparations, and we have extended half-life recombinant preparations. So these three recombinant extended half-life factor VIIIs are also available in India: Adinovate, Aloctate, and Esperoct. And the strategy for lengthening of the half-life includes pegylation or FC fusion or glycopegylation. So these are the various strategies which can be used to extend the half-life of factor VIII. Coming to the factor IX preparations, we have plasma-derived factor IX preparations, we have the standard half-life recombinant factor IX preparations, and we have extended half-life factor IX preparations also available in India. So Refixia is extended half-life. It is a glycopegylated factor IX with half-life of 93 hours, and 1 unit of factor IX increases the factor level by 2.34 unit with the half-life of 93 hours. So single injection is sufficient to prevent or to treat the bleeding episode, and for prophylaxis we need to give once in a week. So coming to the extended half-life clotting factors, technology, but the various technologies are available for half-life prolongation. Commonly used technologies are FC fusion, albumin fusion, the addition of polyethylene glycol, or glycopegylation. So pegylation is one technique which is exploited for the like development of extended half-life factor VIII. So polyethylene glycol is a water-soluble molecule with the molecular weight of 40 kilodalton. So it actually increases the effective size of the molecule, and it also decreases the glomerular filtration from the glomerular capillaries, and it also, so it increases the half-life by three main mechanisms. First, it increases the effective size of the molecule, thereby it reduces the filtration through the kidney. It increases the solubility of the polyethyl glycol, it increases the solubility of the molecule, so it makes the molecule more hydrophilic, and we know that molecules with more water solubility has a these molecules are restricted in the within the circulation, so volume of distribution of these molecules are less compared to the fat soluble molecules, and it also decreases the accessibility to the proteolytic enzyme. So these are the three main mechanisms by which the pagylation and glycopagylation increases the half-life of factor 9. So what are the benefits of extended half-life products? First, it increases the half-life of the molecule, so it improves the pharmacokinetic profile. It elevates the trough level. We can achieve higher trough levels by giving extended half-life factors. Reduce dosing frequency, so dose will be less, frequency will be less. So it is especially beneficial for pediatric patients where venous excess is a problem. It reduces the annual bleeding rate, and it also improves the joint health by improving the trough level with better quality of life, of course. Coming to the treatment of bleed according to the type of hemophilia. So for mild hemophilia A, we can use DDAVP, which increases the release of the stored factor VIII, but it is useful only for patients with mild hemophilia A and VWD. It is not useful for patients with hemophilia B. It can be used in patients with moderate hemophilia, but generally these patients also requires the clotting factor concentrate. Severe hemophilia patients can only be treated by the clotting factor concentrates, be it standard half-life factor 8 or extended half-life factor 8. So mild hemophilia can be treated with DDAVP, but repeated dosing can cause tachyphylaxis. So the more than 3 dose is not advisable for treatment of bleeding episode. Coming to the recommended plasma factor levels and duration of replacement. So for treatment of joint bleed, the desired level of factor 8 is between 40 to 60%. For superficial bleed, muscle bleed with no neurovascular compromise, the desired level is 40 to 60%. For deep bleeds like iliopsoas bleed, the desired factor levels are 80 to 100% for initial 1 to 2 days, followed by 30 to 60% for subsequent 3 to 5 days. For CNS bleed, we need 80 to 100% factor 8 levels for first 7 days, followed by 40-50% in the next 2 to 3 weeks, depending on the hemostatic efficacy and success. For treatment of throat and neck bleed, these are also life-threatening bleeds. So initial 5 to 7 days, the level should be between 80 to 100%. And for maintenance, the level should be between 40 to 50% for 1 to 2 weeks. For treatment of gastrointestinal bleed, the initial levels between 80 to 100% for first week, subsequently around 50% for subsequent 1 to 2 weeks. For renal bleed or hematuria, 50% factor level for 3 to 5 days. For deep laceration, around 50% for 5 to 7 days. For surgery, major surgery, pre and perioperatively, the factor level should be between 80 to 100%. And in the post-operative period, 60 to 80% for first 3 days, followed by around 40-50% in the next 3 days, subsequently 30 to 40% for next 1 week. For minor surgeries, 50 to 80% for in the pre and perioperative period. For post-operative period, the level should be between 30 to 80%. Levels are slightly lower for hemophilia B compared to hemophilia A because of longer half-life and higher trough levels, which can be achieved because of longer half-life. Coming to the prophylaxis, which is also known as regular replacement therapy, and this is the standard of care for patients with hemophilia, because by treating the bleeding episodes, you can only treat the bleeding episode and you cannot prevent the long-term consequences of repeated bleeding. So prophylaxis is the only way by which we can prevent long-term complications associated with hemophilia. And it has been the established as a treatment standard of care for patients with hemophilia A and B, especially severe hemophilia A and B. And in the developed countries, the more than 80-90% patients are on regular prophylaxis, and pediatric patients less than 18 years are almost 100% patients are on regular prophylaxis. In the developing countries also, like South Africa, around 35% pediatric patients below 18 years of age are on regular prophylaxis. In Sri Lanka, around 30% Brazil, 92% pediatric patient, 56% more than 18 years of age are on regular prophylaxis. But condition in India is very dismal, and only less than 10% patients are on regular prophylaxis, and prophylaxis is yet to take root and match the global standards. So prophylaxis is the only way to preserve musculoskeletal function in patients with hemophilia, and there are multiple studies which highlighted the importance of prophylaxis in patients with hemophilia. So prophylaxis is basically regular replacement of hemostatic agent to prevent anticipated bleeding. So this is basically preventive strategy similar to the type 1 diabetes, where we use insulin to prevent the rise in blood glucose. The dosing frequency is different based on the half-life of the product. So for example, if we are using the standard half-life factor 8, the dosing frequency should be every alternate day. For extended half-life factor 8, it can be given every 4th day, every 5th day, or even once in a week also. For the standard and multiple dosing regimens has also been established, like high dose regimen, where the dose for factor 8 is 25 to 40 unit per kg to the like 3 times a week or every alternate day. Intermediate dosing regimen, 15 to 25% every 2 to 3 times, every 2 to 3 days, and low dose regimen like 10 to 15 unit per kg 2 to 3 times in a week. So most commonly used dosing strategy, especially in developing countries, are intermediate dose regimens. So we are also following the intermediate dose regimen. So there are multiple advantages of prophylaxis. So number of bleedings can be reduced drastically by giving prophylaxis. Joint damage can be prevented, or can be like the joint deformity can be improved by giving regular prophylaxis. No life-threatening bleed, so you can prevent life-threatening bleed in patients with hemophilia, especially severe hemophilics, where the chances of life-threatening bleed like intracranial bleeds are always there. Less hospitalization and need for surgeries, less frequent monitoring, better quality of life, and these patients can contribute to the society actively and near normal life expectancy. The biggest challenge in patients with hemophilia is inhibitor development, especially in patients with severe hemophilia A. So inhibitors are actually neutralizing antibodies which binds with the active epitope of the factor 8 or factor 9 and make them ineffective. So we need bypassing agents for treatment of bleeding episode in patients with hemophilia A and hemophilia B. And timing is very, very critical. So first 50 exposure days are the time where chances of development of inhibitor is maximum. And so it is beautifully highlighted in this diagram. So first 50 exposure days are like critical period where the inhibitor development is highest. So you should be vigilant, especially in the first 50 exposure days. And almost like 30% of severe hemophilia A patient will develop inhibitor in the first 50 exposure days. And subsequently, every patient should be monitored for inhibitor at least annually, because the subsequent risk is also not zero even after 150 exposure days. So it is not 0, 1 to 6 per 1,000 patient years. So when should inhibitor be screened? For children, once every 5th exposure day until 20 exposure days, once after every 10 exposure days between 21 to 50 exposure days, and at least 2 times in a year until 150 exposure days. Patients who received intensive treatment or intensive factor 8 or factor 9 replacement should be screened for inhibitors. In adult patients, every patient should be screened for inhibitor at least annually. Patient who fail to respond to the adequate factor concentrate replacement, or who are requiring like higher dose of factor 8 or factor 9 for treatment of bleeding episode, should be screened for inhibitors. And patients who developed repeated breakthrough bleed even on adequate prophylaxis should be screened for inhibitors. Every patient should be screened for inhibitor before like planning for surgery or before proceeding for surgery. So this is very, very critical to like plan for the surgery. So clinical suspicion, when do you suspect inhibitors? So like someone is requiring longer than 3 days of factor replacement in spite of adequate dosing of factor 8 and 9, requires more number of factor 8 or 9 doses than the usual for a particular patient, and unusually higher incidence of breakthrough bleed on regular prophylaxis. So these are the patients in whom we should suspect for inhibitors. Laboratory diagnosis. So lack of response after infusion of 1 to 2 doses of factor 8 or 9. Mixing study. As I already mentioned, if you mix patient's plasma with normal pool plasma, APTT should correct. If it feel like APTT remain prolonged after mixing, so it indicates the inhibitors. And the quantification of inhibitor can be done by Bethesda assay. So how do we approach a case of inhibitor? So inhibitors are divided into three broad categories: low titer, low responder, low titer, high responder, and high titer. So low titer, low responder are the patients where titer is less than 5 and there is no elevation of factor 8 inhibitors after factor 8 exposure. High titer, low titer, high responders are patient where titer is less than 5 BU per ml and antibody titer increases after factor 8 exposure. And high titer inhibitors are more than 5 BU per ml. So why this is important to know the low titer, high titer, and high responder, low responder? Because high titer patient requires bypassing agent for treatment of bleeding episodes. Similarly, low titer, high responder patient also requires bypassing agent for treatment of bleeding episodes. And low titer, low responder patients can be treated with higher doses of factor 8. So we have two bypassing agents available with us. One is plasma-derived APCC. APCC is activated prothrombin complex concentrate, which contains factor 2, 7, 9, and 10, and 7A also. So along with factor inactivated factor 2, 7, 9, and 10, it also contains activated factor 7. And another agent is recombinant factor 7A. So it is recombinant preparation in activated form or active form. So there are various advantages and disadvantages of various like these two preparations, APCC and recombinant factor 7A. APCC is plasma-derived product, whereas recombinant factor 7A is a recombinant product. And the dose is 50 to 200 unit per kg per day. Single dose should not exceed 100 unit per kg. And total dose should not exceed 200 unit per kg per day. So this is very, very important because thromboembolic events has been reported with higher doses of APCC. So one dose should not exceed 100 unit per kg and daily dose should not exceed 200 unit per kg. The doses of recombinant factor 7A is 90 microgram per kilogram every 3 hourly or every 4 hourly, depending on the type and site of bleed. And you can give 270 microgram per kilogram single dose also. Hemostatic efficacy of both the preparations are comparable, close to 90%. But there is theoretical risk of transmission of unknown emerging pathogen with APCC because it is a plasma-derived product. But because of the better inactivation techniques and better understanding of the viral morphology and inactivation techniques, the risk is practically almost zero with APCC. Risk of pathogen transmission is like negligible with recombinant factor 7A because it is a recombinant product. With APCC, the infusion time is slow. So rate of infusion should not exceed 2 unit per kg per minute. But there are studies where higher infusion rates has also been tried and it was safe and effective. So you can escalate infusion rate to 4 to 10 unit per kg per minute also. So instead of like completing the infusion in 30-45 minutes, you can complete in 10-20 minutes also nowadays. The biggest advantage of recombinant factor 7A is it can be given in a very shorter period of time, like 2 to 5 minutes, and with very small volume of infusion. Whereas with APCC, the large volume is required around like 30-40 ml. So, and APCC is not a preferred like treatment option for patients with hemophilia B because it also contains factor 9 and there is a unique problem with hemophilia B with inhibitor because these patients can develop glomerulonephritis or anaphylaxis when exposed with factor 9 with inhibitors. So the preferred option for treatment of bleeding episode for hemophilia B with inhibitor is recombinant factor 7A. And both the preparation can be used for hemophilia A and B, but preferred option is recombinant factor 7A for hemophilia B with inhibitors. We have non-factor therapies also available with us in the form of emicizumab, and concizumab has been approved in various countries and very shortly it will be available. Fitusiran is siRNA. So coming to the emicizumab. Emicizumab is a bispecific monoclonal humanized IgG antibody with two arms. One arm of emicizumab binds with activated factor 9. Another arm binds with the factor 10 and it causes factor 8 independent activation of factor 10. So it works like factor 8, but it is a monoclonal antibody and it is a non-factor preparation. Biggest advantage of emicizumab is it can be given subcutaneously once in a week, once in every 2 weeks, or once in every 4 weeks. So like wide range of flexibility is there, subcutaneous, and it can be given once in a month also. And it mimics the factor 8 function irrespective of the presence of factor 8 inhibitor. So it can be used for hemophilia A with inhibitor or without inhibitor, but it requires factor 9A, activated factor 9. So it is ineffective in patients with hemophilia B. So it is treatment option for only for patients of hemophilia A. So it can be used in all age groups, and it has been extensively investigated in the landmark clinical trial for patients less than 12 years of age, more than 12 years of age, with inhibitors and without inhibitors. And but it is only approved for prophylaxis. It is not for treatment of bleeding episodes. Second monoclonal antibody is concizumab. So it is a basically tissue factor pathway inhibitors, and it causes rebalancing of the clotting mechanism by inhibiting the tissue factor pathway, which is the anticoagulation pathway. So it was investigated in the this landmark clinical trial, and based on this trial, it was approved for treatment of both for prophylaxis for both in patients with hemophilia A and hemophilia B. So other rebalancing agents are like inhibitors of tissue factor pathway like concizumab. Other molecules are also in the pipeline. Inhibition of activated protein C and protein C, inhibition of protein S. Some are daily, some are weekly, some are monthly, and subcutaneous preparations are also there. So molecules which are in progress or which are in the like under clinical trial, marstacimab, very soon it will be available. Concizumab has been approved for prophylaxis for hemophilia A and hemophilia B with and without inhibitors. So multiple preparations are under trial. Gene therapy is still like experimental and very costly, and it is like not reachable for majority of patients, and still standard of care is prophylaxis with clotting factors or non-factor therapy. So it is basically the correction of the gene and delivering the corrected gene by the viral vector, and it causes the expression of the factor 8 or factor 9 gene in the patients. So previously we have standard half-life factors. Now we have extended half-life factor from 2014 onwards. Now we have non-replacement therapy in the form of concizumab or emicizumab. Gene therapy will be definitely future, but still it is not a standard of care, and it is still like experimental strategy for hemophilia A and B. So to conclude, hemophilia is rare bleeding disorder due to deficiency of factor 8 and factor 9. Prophylaxis is the only way to prevent long-term complications and improve quality of life of hemophilia patients. Early and appropriate doses of CFC should be used to treat any bleeding episode, including life-threatening bleeds like intracranial bleed. Inhibitors are a real challenge in hemophilia, especially in patients with severe hemophilia A, where lifetime risk of developing inhibitor is like 30-40%. Non-factor therapies are available, and I think these therapies will replace the standard of care clotting factor for prophylaxis. Gene therapy is curative modality, but still in experimental phase. So this is all about hemophilia. Thank you very much for your patient listening.
That was a marvelous lecture, Dr. Vishnu.
Thank you, sir.
Seeing the constraints that we put on you, you were very kind, and we apologize for the entire goof of today. Thank you, dear students, for the nice attendance. And we have one question only.
Yes, sir.
Dr. Vishnu, can you be comfortable in answering? You have actually
sir,
answered
sure.
you have actually answered during the talk, but
Yes,
let's
sir.
keep the question for you.
Yes, sir.
Daughter of a hemophilia father became pregnant, and they have checked for the factor 8 level, which was 1%. So how do we proceed?
So someone comes with factor 8 level less than 1%.
Hmm.
This is your question, sir?
Yes, yes, yes.
So, see, the standard of care for hemophilia A and B, especially when factor levels are 1% or less than 1% with bleeding phenotype of severe type. So these are the patients where prophylaxis is the only way to prevent long-term complications. So every patient with factor 8 level 1%, less than 1% with bleeding phenotype of severe hemophilia should be put on regular prophylaxis, because prophylaxis is the only modality by which we can prevent long-term complications associated with repeated bleeding. So every patient should be put on prophylaxis, uh, especially when bleeding phenotype is severe.
Right, sir. As I already told, this question was answered during the talk. So this question, yet we have put it. Dr. Sudhir sir has joined. Dr. Sudhir,
Yes,
sir.
yes, I'm very much there. Yeah,
Uh,
thank you, Dr. Vishnu. I think you have elaborated very well the take-home message for the physicians and residents, how to recognize and treat hemophilic patients. And I think, and you have completed well in time. That's very important. Within that short period, of course, because of miscommunication, we are not able to give you a link. But at the end of the, I think that talk has been a quite a delightful lecture. It has been quite informative, and I think all the physicians and attendees, PG students especially, they would benefit a lot, and they probably it will this your information what you have provided will help in day-to-day care of these hemophilic patients. Thank you, Dr. Vishnu.
Thank you, sir.
Thank you. Thank you, sir. And remember, students, this is a YouTube recording also. So we would be having this lecture on the YouTube, and you can attend this while on your leisure time. Meanwhile, Dr. Vishnu, thank you from the core of my heart for a wonderful and comprehensive lecture that you put on hemophilia, and Dr. Sudhir Mehta, sir, for a wonderful program that you have carved for this hematology clinical updates. Thank you very much. Thank you, everyone.
Thank you,
Can we
everybody. Thank you,
can
Dr.
we
Mid.
end
Thank
the
you, Pankaj.
session? Yeah.
Yes. Thank you, Dr. Mid.
Bye.
Thank you, Dr. Vishnu.
Thank you, sir. Thank you, sir.